So you're monitoring your intubated patient when their condition begins to deteriorate. What do you do?
Oh, doctors, eh? I'll doctor you. Come to this institution.
Have no fear. We have a mnemonic for that. A mnemonic specifically designed to address the needs of the intubated patient. And that mnemonic is D.O.P.E. D-O.P.E. And this stands for D, displaced tube. O, obstructed tube. P, pneumothorax. And E, equipment failure. Now, anytime your patient is deteriorating that is intubated, always start from the patient and work toward the machinery. So if they're on a ventilator, don't mess with the ventilator, go to the patient first. If they're unable to exchange gases, you can't get air in or out of them, they come off the ventilator and we're gonna bag the patient. Then we can play with the ventilator. So first, D, displaced tube. This should be really easy to pick up because all intubated patients should have continuous waveform capnography being performed. This gives you a breath-by-breath analysis and confirmation of the correct tube placement. If that tube pops out, remember that end tidal is reading exhaled CO2. If that drops to 0 in the intubated patient, they're not exhaling CO2. The machine is not picking it up. This is classic for a displaced tube. Check the patient first, then towards the machine. Next, O, an obstructed ET tube. Now, if you're transferring a patient who's intubated, you must have a Ballard suction, inline suction device already attached to the patient and ready to go. This allows you to suck out mucus or plugs, stuff out of the ET tube without opening the vent circuit, without contaminating anything. It's a completely closed circuit. So, use your Ballard suction. Next, pneumothorax. I've needled a lot of chests in my career. And when I look back on it, every one of them was an intubated patient, usually a trauma patient who was intubated and then developed a pneumothorax. Now, just being on positive pressure ventilation, being on a ventilator, or being bagged by a provider puts the patient at a higher risk for developing a pneumothorax. Remember, normally we breathe under negative pressure. When we're bagging or the patient's on a ventilator, that's positive pressure ventilation, and you have to watch for a developing pneumothorax. Now, on a ventilator, your patient can develop a tension pneumothorax within just a few breaths. The last patient I flew when I was working for this helicopter team was a trauma patient, and right before we left, the high pressure alarm goes off on the ventilator. I take him off the vent, I hook him up to the bag, I go to bag him, he's a brick. I can't get any air into this guy. I listen on the left side, I got some sounds here, I have no lung sounds on the right side. Pull the needle I have in my pocket, pulled it out, needled the chest, started to bag him, and within a few breaths I had compliance. I was able to get air in and out of the patient. You must always be prepared for a pneumothorax in the intubated patient. Last, equipment failure. You ran out of oxygen. This happens. So the next time, before you take the patient from the ER to the CAT scan, take a peek under the cot, make sure you got a full tank of oxygen. If you're in a rig or in a critical care rig, remember to check both your oxygen and air levels. If you're blending on a ventilator, if you're blending that FiO2, that requires both an O2 source and an air source. And make sure all your equipment is mission ready. So this has been a quick mnemonic, D.O.P.E, how to address your crumping intubated patient. I'm Mark, thanks for watching, we'll see you in the next video.